well so that we can kind of continue conversations as needed, but we'll go ahead and get started. So tonight we're talking about the ABOM exam and paths to getting started in obesity medicine. And I do just want to put a disclaimer out there that neither Kevin or I work for ABOM. This is just something we are doing because we get a lot of questions about this. We're both very passionate about obesity medicine. So we don't work for ABOM. We're not representing anyone other than ourselves in this talk. So welcome, little background on me, and then we'll have Kevin give his background as well. I'm a family physician by training. I discovered obesity medicine when it was called bariatric medicine. While I was in my residency training, I went into family medicine residency knowing I wanted to do something with nutrition and wellness and prevention. Told my advisor, about this, and she said, oh, we have a doctor, who sometimes people do a rotation with. And it turned out that doctor did bariatric medicine, and I just fell in love. I was like, this is what I want to do with my life. So I knew in residency that I wanted to do this. I took advantage of the discounted CME through the Obesity Medicine Association. And right after I took my family medicine board, a few months later, I took my obesity medicine board, and I've been practicing a combination of obesity medicine and family medicine since then. I actually started doing some obesity medicine even during my residency training. I have my own private practice in the Denver area where two of us do obesity medicine and two do family. And I still do a mixture of both, which I really enjoy. I also have weight care consulting and help your patients lose weight, which are ways that I help clinicians treat obesity and feel more confident in doing that. I teach. And I am now a board member for the OMA. I am not representing them in any way tonight. Again, this is just me speaking for myself. I represent private practice physicians at the AMA. And something we'll talk about a little bit later, I have a course to help people, actually implement obesity medicine in their practice. So that's my little highlight. I'm really excited to share this field with you all. I think we have the most positive group of clinicians. Everyone is so collaborative. They're so happy. If you haven't come to a conference, it really is just like the happiest group of doctors. I don't think we have a lot of burnout in our field because we're really helping people every day. And it's a field where there's constantly like new things coming out. We're learning a lot. We're having better and better tools to help our patients. So hopefully this will just be like a little inspiring to all of you that this is a fantastic field if you're not already on your path to getting into it. All right, I'll turn it over to Kevin.
All right, so I'm Kevin Smith. I'm an assistant professor at the University of Oklahoma and got into obesity medicine for a couple different things. One, I kind of got asked to help out with some of the bariatric surgery stuff, the pre-op stuff. And that was kind of my first inlet. I was the newbie on staff. And so I kind of got roped into helping out with the pre-op stuff, but really had a passion more for also incorporating medicine and lifestyle changes and things like that as well. And so it was a great fit and helping out patients who wanted to end up going the surgery route versus patients who wanted to stick with more medication management and lifestyle changes, both of those being incorporated into the surgery arm as well. But it's one of those things that you kind of just get hooked. I started off, I hadn't gone through boards, ABOM boards at that time. I was internal medicine trained. And so anyway, it was one of those things I felt like I was just trying to learn so much on my own since most residency programs, in the past few years haven't made a huge focus on that. And I think that's starting to change as well, but it's something that I really wanted to just know more about. So I started looking into it, started reading the guidelines and the recommendations, and eventually was, like I said, I was hooked and wanted to end up doing the ABOM boards. And so I ended up doing that. COVID kind of put a little delay on that. So it got delayed an extra year. But I ended up getting that completed and going through that. And so we get a lot of exposure with residents and helping out with them as well in this area, which is just a lot of fun. And like Carolyn said, it's one of those things where you get hooked. It's exciting. You have patients that come back and they've done well. They feel good. They're excited. You're excited. And so it's a really fun field to be in terms of that. I have a kind of a little interesting hobby, I would call it, just something that I really enjoy. I have this odd desire for board review and making sure that, whether it's obesity medicine boards or internal medicine boards, just helping students reach their goals in that and be able to pass it. And we'll talk about some of this in the future as well. But that boards are always one of those scary things. And so it's kind of my passion to help people who want to have that knowledge, who want to be able to pass boards and move into that and get certified to help out with that process. And so when I was practicing, or when I was trying to do board review questions and try and learn as much as I could, I really found out there's not a whole lot of board review questions out there. And so given that's one of my passions, I decided to kind of combine that. And so I ended up writing a book that helps, me actually. It was kind of directed at me at the beginning, and now it's fortunately has helped out some others as well along the way. But in terms of providing quality questions and trying to organize the thought process behind questions and topics related to obesity medicine, so it's easier to pass those boards as well. So that's kind of a subset of my passion, but I just really enjoy obesity medicine. I hope we can convince you, if you have thought about it, if you're interested in it all, to kind of go this route and to explore it, because it's very rewarding and an exciting career, and it's growing. And anyway, we'll get into some of that here in a little bit. I don't want to jump ahead. It's
really like a field where I don't think any of us feel competition, right? We're like, there's enough work for all of us, and really, I just think incredibly collegial. Kevin and I actually just met at the last OMA conference, and I'd heard his name and I was like, what? There's like review questions now? Because when I took the board in 2014, there really wasn't anything. And he was kind enough to show me his books. And I was like, these are amazing. Like, what a resource. So you guys, if you're considering taking the exam, are in a totally different place than we were, 8 or 10 years ago when the stuff didn't exist. So it's a pretty cool resource. So, okay. So the questions we kind of said that we both kind of feel like we answer a lot, that we see a lot are, is this field worth it? Can any specialty practice? Do we need to take the exam? How do we prepare? And what do we do after the exam? So we're going to kind of cover those, and then we'll get to some of your other questions as well. And I have a terrible tickle in my throat. So apologies. At least you can't get like COVID from a video screen, right? So, the first question is practicing obesity medicine worth it? Kevin, do you want to start off with your impression on that? I feel like we already touched a little bit about how much we love it, but yeah, tell us a little bit about what you think about, if it's worth it.
Yeah, no, for sure. It's something. I'm internal medicine physician, so I do primary care and hospital medicine. And one of the things that we just constantly see is we're treating all these symptoms of an underlying disease of obesity, and instead of treating those symptoms, sometimes targeting the actual excess weight is a great way to have an impact on broader areas. And so I think one of the coolest things is, and one of the things that will hook you when you start, is you have a patient that's motivated. You work with them, whether it's lifestyle changes, incorporating behavioral changes, and possible medications. They start losing weight and they start coming off of those medicines. Their diabetes is improving, their hypertension is improving. You have to actually back down on medicines, which isn't something that I feel like we get a lot of exposure to in everyday primary care practice. And so it's worth it to the patients. The patients, just they get excited about this stuff. This can be life-changing to them. Things that they wanted to do and weren't able to, now they're able to do. I've had patients that, I always ask what their goals are kind of at the beginning. And some of them are as simple as, I want to be able to play with my grandkids. One was, I want to take my grandchild to amusement parks and not have to sit down and rest. And so that was his goal. And so just helping these patients meet their goals wherever they're at is for sure worth it. I think it's, there's very few things that make you as excited as when you're able to help someone reach their goals personally. So I think that's a key point. In just the patient population. I'll let Carolynn talk a little bit more about financial and job opportunities as well. Just kind of as a background, I practice a lot of primary care, but I also have a dedicated day where I do obesity medicine, and that's my whole population, but it's really integrated throughout primary care as well. And so it's kind of a different approach, and it's in an academic setting. So the job opportunities and things like that may be a little bit more in Carolynn's field.
Well, I think there's so many different approaches, right? And so I think one thing is to recognize this is not a specialty in the same way that like cardiology is, right? Where there's a standard 3-year fellowship and it's certified by like the American Society of Specialties. It may be there someday, and there's this constant rumor that like this is the last year that you can take the exam without a fellowship. That rumor's been going on since at least 2013 when I decided to take the exam. And everything I know is that that is, you know, maybe someday not on the horizon. And I feel like we'd get lots of notice on that. So, you know, I think some occasionally I've had people who are like, well, I did this and I can't get a job in the field. A lot of this is a job you have to create for yourself. And there are more and more job opportunities, but when they've surveyed in the past, the OMA actually did a survey and they showed that people practicing obesity medicine on average make the same as they did in primary care. So this isn't something where all of a sudden you're going to have like a job fall in your lap or, you know, a raise through your employer necessarily. So I think that that's probably not the reason that people are doing this. Certainly on the private practice side, there are physicians doing incredibly well in this field because, you know, sometimes they can streamline things, they can sell additional products, there is a large demand. And so, you know, the financial is really up to you. You should make the same as primary care, but the sky's the limit depending on where you go. But I think why people keep doing this is the career satisfaction. We went into medicine to help people. And with this skill set, like Kevin was saying, we're taking people off meds. Our patients are grateful. They thank you all the time. I've seen patients who they refer their friends and family to me after the first visit. They haven't lost any weight. They haven't had, you know, any results, and yet they already recommend me to people. And it's because I am able to explain what's going on with their body and explain that it's not their fault. And for the first time, they feel heard and justified. And so reducing that bias and stigma in this population is really, I think, powerful and rewarding as well. So there is definitely opportunities that are growing in this field. A lot of bariatric programs are wanting to hire physicians that have this training. And so that is something that has definitely expanded over the last few years. It's sort of becoming standard, I would say, Kevin, that like these bariatric programs want a physician who can do some of the med management. So that's growing, but certainly I wouldn't say, oh, you're going to take the exam and, you know, have job offers in your lap. You may have to make that position a little bit for yourself and start integrating it into your practice. Or I, of course, am a huge advocate for private practice and starting your own thing. So I think those are some of the things to consider that I think the majority of people start with this because it's a passion and they want to add it to what they're doing, and where it goes career-wise from there is really, I think, in your hands on how it will work for you.
And I'll just add to that too is I feel like once patients know that you have kind of specialized in that area or that you have a special interest and increased knowledge based on that, referrals just kind of pile up. I don't know how many times you hear, you know, oh, you know, this person told me about you, or even I've had a psychiatrist that treated one of her patients who just kind of self-referred and it was on a lot of obesogenic medications that we were able to, you know, start medications to kind of help counter that and discuss those with her. You know, now she refers a lot of patients. So I feel like you can really set up referral streams pretty quickly. Word of mouth is probably the strongest way, and it goes quickly. I mean, I could add multiple days of clinic doing obesity medicine just from that standpoint, and so it's definitely the demand is there, like she's saying, and you know,
yeah, we had a new doc start at our clinic, and with overflow from me and, you know, advertising her just a tiny bit, she was full within months. It really is definitely in high demand. So you'll have no shortage of patients, I think, if you learn this skill set, and really grateful patients too. All right. So I think this is a question that I have gotten a lot, which is like, do I need to take the exam? And so I think there's a lot of things to consider with this. Of course, I took it right away. It was something that was really exciting and important to me. And I think it does a few things. I think it does add to credibility, right? If you can say, like, I am a diplomate of the American Board of Obesity Medicine, I've specialized in this, I've done the required training, I've taken the exam, that helps position you as an expert in the field. And so I think a lot of times when you're talking with other physicians, that definitely adds a layer of credibility. I think there's a huge experience with learning and studying, which Kevin took to another level by writing questions as he did it. But to really understand the science and the data is, I think, also very helpful for a lot of people. I don't personally think that studying for the ABOM exam always gives you all the tools that you need to clinically practice, just like anything else, right? Presumably, if you're, thinking about taking this board exam, you passed your USMLE boards or whatever boards you had to pass, and passing the board doesn't mean that you're ready to go be a doctor, right? Those are very different things. And so I would say the same thing for this exam, where taking the exam, for some people, they don't quite feel like they know all the clinical side of things. So if you just want to implement this clinically, but maybe you don't want to truly feel like you're specializing, right? You're like, I don't know, I want to help treat my patients with obesity, but maybe I don't want to do this full time or have a dedicated day. I just want more skills. You don't need the exam. And I think that is, we need more people treating obesity. We don't need every single doctor who wants to help with this taking the exam. You can always refer up, right? If it gets too complicated, the patient needs something that feels out of your scope in whatever you're doing, refer to someone like Kevin or I who do this kind of full time. But, I think that one of the drawbacks of the exam is it makes people feel like if they didn't take the exam, if they didn't do special training, that they can't treat obesity, which is definitely not true. We just have to recognize our skill set. The one group that I often recommend do take the exam are people where obesity treatment may not be part of your regular scope. So for those of us in primary care, we're treating obesity using some of these meds probably already, right? We're treating diabetes, we're treating hypertension, we're treating mood disorders. And so a lot of the medications and skill set for obesity translate, but sometimes people decide they want to get into this field and maybe they are a pediatrician and they want to be able to help whole families now. And so they, maybe don't have as much adult experience post-medical school. Maybe they're in a specialty like radiology and are deciding to go into this field. I've actually talked to someone who's doing that. So all to say, I think it does help with credibility. And if obesity doesn't feel like it is already part of your scope, that may be a good reason to take the exam, because you can come from any specialty and take the exam. So that's kind of cool about this. You can come from OBGYN, family, internal medicine, cardiology, endocrine. You could be a surgeon. There's actually a handful of bariatric surgeons who have taken the exam to learn this skill set. So anyone can do it from any specialty. You do have to have a specialty to be able to take the exam. And again, I think it can add to credibility. It can formalize the training, but I don't think it should be a barrier to anyone feeling like they get started on this treatment for their patients. What are your thoughts, Kevin?
No, I totally agree. I mean, I kind of think of this is a test for either DOs or MDs, right? So there's a ton of nurse practitioners and NPs that are out there practicing obesity medicine and doing a fantastic job, and they don't have this ABOM exam under their belt. There's other certifications for them that they can get, but I just think of those, that's a great example of people who are practicing obesity medicine and doing a great job within their fields and don't have this test. I also I like to think I'm more motivated probably than I am. But if I hadn't taken the exam as well, I probably wouldn't have taken the time on my own to start learning about physiology and kind of all this, specific guidelines on things for, preoperative stuff and what, there's just so much related to it as well. And so I learned a lot through the exam process because you have to know it to take the test. And so I think there's a lot of validity to it if you're planning to, like Carolynn said, if you're in an area that maybe this is kind of an uncomfortable area for you, you don't see a lot of, you don't cover a lot of primary care stuff, and so it's outside of your scope. But I think it does help you just understand things, kind of the why we're doing things as well, and not just knowing how exactly to do it. But it's not for everyone. I don't think everyone, like she was saying, there's just so much of a demand that if you're interested in obesity medicine at all, I think there's great training resources out there. There's, Carolynn has a course in that practicality part. I don't think you should feel like you don't feel qualified as well in treating patients who have obesity if you don't have the certification. So I totally agree. I think that's sometimes can be this barrier that you feel like I need this training for people to trust me, and it's not. It's a process that you can gain experience and knowledge to other areas as well. But if this is something that you want to kind of devote more time to, I think it's just an excellent resource that really, like it says on there, gives you some credibility amongst different people. I think surgeons are a great example if you can help them out with the pre-op and the post-op process and following these patients along, and it just can provide some extra information and training on that as well.
Yeah. And I think I have heard that some of the new like telehealth platforms that are popping up do require or prefer the exam. So that may be an option or reason to take it as well. Though I would always recommend you just start your own practice. Okay. So how do you prepare for the ABOM exam? So I pulled this directly from their website. So we'll just go through this for those of you who haven't looked at this. You need 60 credits of CME. In the past, you had to do 30 in person, but with COVID, obviously that has not been practical or even possible for certain periods of time. So currently they are allowing that to be online, but they have 30 credits that are very like specific. It has to be approved by them through some of their partners like OMA and TOS and Cornell, I think, like Columbia, I don't know, one of those other schools. So they have some very specific ones that are listed on their website that you have to do 30 of. And then the other 30, you can do whatever you want as long as they have the word obesity in them and are what are truly AMA, PRA category 1 CME credits. And so I think that's a great opportunity to learn what you need for your patient population, right? So, 30 hours needs to be what they recommend. Highly recommend some sort of board review class for that. That's essential. I think you have to take at least a board review course, but then you have 30 credits that you can do what you want with. So if you're going to focus on peds, do all of that on peds, right? Because that's for you. You don't, the 60 hours is not necessary to take the exam, right? The board review course, probably necessary. Everything else is, I think, bonus and should be focused on what is going to help you actually practice. So that would be my recommendation there. You can do all the ones that are recommended through them. So that's fine too. So that's currently what they require for the exam. And, I think Kevin, you're like the guru on preparing for the exam. So what are your thoughts? What are your tips and tricks? And what do you think?
I think it's a lot like any board exam that we've taken. The more board review questions you can do tends to make you feel more confident and kind of shows deficits as well that you can kind of hone in on and work on. And so I think as far as preparation part, I think, yeah, absolutely. One of the board review programs, I did OMA and I thought it was fantastic. And I follow a couple of other ones just to keep the book updated as well. But get a good quality one and go through it and listen to it, 1 or 2 times. I think that's a great way to start and kind of get an idea of what's included in that. Get as many board review questions as you can. I have some book questions, but the ABOM actually has 50 questions that you can sign up for, and they'll send you some examples as well. There's other places that have questions, other societies as well that are good quality ones. So just make sure that you're doing questions and finding deficits, and when you find a deficit, work on that area. As far as the other credits, I agree. I think if you can focus, some on, obviously, if you're planning to take boards, do the board review, but other ones that are going to be more in line with your practice, whether it's pediatrics or adult medicine, GYN, there's tons of different resources out there that kind of focus on that area. And those are always good ones to practicality wise, be able to jump into and go through as well. I would say, like I said, I'm internal medicine, adult medicine trained, right? And I was kind of nervous because the pediatric portion is something I have not thought about and don't really have, obviously, patients that are in the pediatric population. So that was something I was a little bit concerned about. But the test overall is mostly a general test as far as general knowledge. Yes, there's going to be some where you're going to have pediatric patients and you have to know what age you can start these medicines and things like that. 85% of the test is more general medicine based. And so whether pediatrics or adult medicine or anything in between. It's going to be things that are going to be more generalized to larger groups. So don't let that be a deterrent either, that you have to learn just tons and tons of pediatrics. You have to know some genetic things and things that are actually going to help you out, even if you do only practice adult medicine. But it shouldn't be a barrier at all either.
Yeah, I think the pediatrics is often the most intimidating, even as a family physician, just because it is very like focused information. And they have a lot of resources listed on their site. But there is like, the OMA has a pediatric algorithm now, as well as their regular algorithm. And so there is resources out there to learn that. So I agree. It's like finding your deficit and figuring out like what you really need to learn. I think I listened to the board review course like maybe 5 or 6 times. I just put it on in my car and just like listen to it over and over again. And that really helped me learn some of like the population data and the nutrition, like remembering every micronutrient deficiency and some of that stuff. And then I didn't spend a lot of designated time studying. I did whatever questions existed, which there was not very many. I think there was only the ones from ABOM back then. So I don't think there was anyone else who created any back then. And then, like some of the neurobiology was just, I think what was complicated. So I remember, making some sheets and some stuff for that, made my own little study guide back then. But, I think the review courses are essential for it. And like you said, just figuring out, okay, what about this don't I quite understand, or do I need to study? There are textbooks that are listed always as study guide. And I'll be honest, I didn't utilize those at all. I found the review course and then just picking out things that I didn't completely understand or needed to study more, and really just focusing on those was how I prepared.
I'll say that the book that I wrote, the first edition, was while I was taking boards. And so it was kind of my notes, and I would go through that a lot, right? After I took boards, the second edition came off, and that was all the stuff that I was like, this could probably be bulked up. And this was something that I kind of glossed over. I didn't think it was going to be a question on boards, and it did. So if you end up using that, just kind of looking at that, because those are things, some of them you're like, do I really need to know about resting energy and all this stuff? There's going to be a couple questions on there. And so some of those oddball things that you kind of aren't thinking about, if you end up going through the book, it does touch base on those. And that's wise, because I was kind of thrown off a little bit and kind of maybe didn't study that as much as I should on the first one. So, and all the questions too are taken actually from study review programs. And so that's something that I use personally. And I had some friends that were using it at the same time. That I think just having those notes and high yield points, it can sometimes help out just with those questions too.
Okay, I think we covered our thoughts on there as well. So what do we do after the exam, right? And that's where, some of the tools I've created, I feel like, come in. Is I met a lot of physicians who took the exam and they were like, okay, but what do I do with it? Like, how do I actually practice obesity medicine? Because most of us don't have the opportunity to see someone do that. I got to do a month-long rotation in residency because I knew I wanted to do this. And I did as much little bits and pieces of training as I could. I hung out with the bariatric surgeons whenever I was allowed to, did most of my surgery rotation with them, and shadowed some other people like Ethan Lazarus for a day, talked Eric Westman's ear off at a conference once. So, I utilized whatever I could to get that training. And I know that most people don't have some of those connections or the time to do that if you're already established in your career. And so after getting this question probably 30 or 40 times and having people want to come to my office and meet with me and shadow, I was like, there's a lot of demand for this. So I actually made a course called the Obesity Medicine Startup Course and Toolkit, and it's 13 hours. It actually does qualify for that board CME because it is approved through the AMA PRA Category 1 CME process. And it basically is like an invitation to my clinic. There are videoed mock patient encounters. It really walks systematically through how I treat obesity, including like 60 pages of like handouts and forms that I use for my clinic. So I didn't want there to be any barriers to people actually using this skill. You've invested time, you've invested money. And it was making me really sad that people were like, okay, but like, what do I do with this? Right. They were like expecting something to fall in their lap, or they weren't really sure how to get started and they already had a job. So they were just going to keep doing that. So, I'd say don't be afraid to start wherever you can, right? You might start with something simple. I had a handout I made in residency, and I started with this one handout called the Healthy Eating Plan. And I have now like a couple dozen handouts that I have added over time, and that help me streamline things and make sure that I cover some of the important things with patients, and that I have something tangible, and that I don't have to remember everything with every patient. And it also, I think, makes me look more credible with my patients, right? Like, I'm not making this stuff as I go along. Like, here's my handout, here's the nutrition plan. So you can start small, right? You don't have to have it all at once. So start with a handout, or if you want 60 pages of them, you can start with me and you can make that easier for yourself. The OMA also sells some handouts, and there's a few other places where those tools are available. So use your tools. If you invest the time in this exam, utilize it, right? I know lots of people who don't, and I think that's a big bummer, right? Like, you should use this. Our patients really, really need it. And then I would recommend, if you take the exam, like, make a big deal out of it, right? Like, it's okay to announce it in a newsletter to your patients or your institution. I think the ABOM actually gives you a press release information when you pass. And so they give you this little graphic you can put on your emails and stuff. And I think they actually have this worded press release. So if you want to do a press release for yourself about it, you can do that. And that grows awareness of the whole field, right? So it really helps all of us help our patients when people know that this exists. And then I would say, practice, if you haven't already, explaining what this is and why you do it. So I have my little elevator pitch, I guess, that I've done a million times at this point, because once you start talking about this, every patient wants to know about it. And most of your friends and family want to know too. Like, everyone, unfortunately, there's this culture towards weight loss. And sometimes that's unfortunate, but people want to know about this. So I always kind of explain, obesity medicine uses multiple components for treatment. So we look for underlying causes, we use nutrition, we use exercise, we use behavior change. And the big tool we bring to the table is medications. We actually have multiple medications now that can help people lose weight. And so, that kind of succinctly tells people what I do. And for other clinicians, they're often like, I had no idea. I didn't know about these meds. Or, can you tell me about these meds? People are starting to hear about Wegovy, right? How does that work? Does it really work? But do they have to take it forever? And so, once you can start being a resource for other physicians in your community and your patients, you'll be able to really grow that practice. So don't underestimate how much you know and your ability to do this. And then I think having your why, Kevin and I both explained, we see our patients get better. We see people go off of medicines. We see people happier. And so it's, that's why we do this, is it actually helps our patients. So that's my sort of and then one thing to know about the ABOM exam is you have two options afterwards. You can retake the exam every 10 years now, 7 years?
Yeah, 10.
Or you can do longitudinal journal review with questions, which I would highly recommend. It's really fun. You get to read journal articles that you might otherwise not find time to read, and answer some usually pretty straightforward questions. So, there's two options long-term so that you can maintain that certification.
I told Carolynn when I met her that if I knew about her course when I was starting off, that would have saved me a ton of time in making templates and just kind of my organization. I felt like I was learning all these things, but trying to put it into more succinct and just handouts and things for the patients. I think that's just a huge benefit that you could acquire from that course. And so definitely would check that part out. And I agree. I think it's one of those things that once you start to get a little bit more confidence. You may not do everything perfect at the beginning. I didn't. But I was trying to do my best, and my patients appreciated that. And as I got more knowledge, and as I went to more CMEs and eventually took ABOM, it was one of those things that that confidence grows in you as well. I think that's the biggest thing is, you feel like you have to have all of this information before you can start. No, the patients want, they appreciate the input and the help that you give them, even if it's small, and that grows over time. And I have a lot of my primary care patients that, once I started getting into this, that we said, hey, let's devote a whole session to just excess weight and what we can do to kind of help out with that. And so starting small and growing is a great way. Word gets out, like we kind of talked about as well. And then another way is reaching out to surgeons surgeons. Surgeons have a lot of patients that may not be surgical candidates where they're at. Maybe the patients, they want surgery. They have that in their mindset that this is the way I want to go. But maybe they're not, at that point, maybe their BMI is too high for the surgeon to feel comfortable. Maybe there's things that they want to help out metabolically or diabetes wise. And so I found that's a great resource, as well as just talking with the surgeon saying, hey, if you have any complicated patients that are planning for bariatric surgery, but need a little bit of extra help, send them my way. Like I'd be happy to invest that time. And surgeons are usually happy to hand off the medicine side as well. And so I think that's another great resource that you could throw in there, or a great pitch for other specialties to kind of help bridge that gap as well.
Awesome. We'll open up to some of the questions that people have been putting in there. So feel free to toss more in there. Here's our contact information. Our emails are on here, our websites. I'm helpyourpatientsloseweight.com and Kevin is obesitymedicinereview.com. So pretty easy to remember. They tell you exactly, what you will get when you go to those sites. I have the 13-hour course that's CME approved, and tentatively my next mini course, which is a 3-hour course that does not have CME associated with it, is going to be Saturday, August 13th. And then I also offer consults if you're trying to figure out how to, get started, how to make this practice work, or how a private practice might work for you. And you can book those on the site or by emailing me, because sometimes I don't have a ton of availability list on there. And then if you want to follow, I post pearls on these 2 sites. And then Kevin, again, he's got his email on here, obesitymedicinereview.com. His 435 board review questions, that's ridiculous. That's a lot. That is a labor of love right there. And his books, which are on Amazon, I'm sure there's other places you can get them. His website, you can get them there. And also has a blog. I think we both just really love what we're doing and want to see other people doing this. And we're like, we have this knowledge, like, how can we share it? So, okay. So I'm going to go through some of the chat questions. So, first one I'll answer is, I have wanted to take the ABOM exam, but I'm hesitant because it's not recognized by ABMS. So I think that there is potentially this long-term goal that it would be, but what that might look like and why that might be important varies. That ultimately doesn't matter for everyone, because at the end of the day, it's not like you get paid more by being an obesity specialist. So, I guess I don't know that that's a reason not to take it. And things that are ABMS are usually something that's like multiple years a fellowship. So this is something you can do on your own time. And, I think the benefits of like having this additional certification for a pretty minimal time and financial investment compared to becoming like an endocrinologist, for example, probably makes sense for most people. But at the same time, like, you don't need it to practice obesity medicine. It's just going to give you that deeper level of knowledge and maybe some additional credibility. But there's certainly great people out there practicing obesity medicine who aren't eligible to take the board exam, or, haven't found it relevant. They don't need to. They're already busy. They're already well acknowledged within the community. And so, I don't think you need to do it. I think it gives you that bigger depth of knowledge and potentially some credibility. Question about if it makes a difference taking the exam, I think, for insurance coverage for prescribing meds. So that's a great question. And right now, I am not aware of very many situations, but I know at least one state was doing a pilot program covering some of the medications. And one of the things in the pilot program was only people that were ABOM could prescribe the meds. So that's definitely a possibility. I know as a family doc, I feel like pretty much everything is in my scope, and I occasionally get rejections for stimulants for ADHD. The insurance says they have to see a psychiatrist, or recently a migraine med, they wanted the patient to see a neurologist. And so I think that's a possibility that could happen, especially with some of these newer, more expensive meds that are coming out. So I think that's a valid question is, could insurance require someone to see an obesity specialist to get the meds? I would personally fight that from the advocacy side, because obviously this is something that should be in the scope of most physicians. But I think that's a valid concern that may be happening in very, very rare environments. Edwin is asking, I'm currently a PGY2. I love that you're already doing this. Could I start working on completing the CME credits now, or do they have to be completed in the year once you take the exam? And then someone else answered, you have 36 months. So I'm not 100% sure on that, but that sounds correct. I would definitely check the ABOM website and correspond with them directly. They're very responsive if you reach out to them, in my experience. But I know that I started earning credits when I was in residency for it. So, and at least the OMA has great resident discounts. So, definitely a way to earn that CME while potentially your residency program's paying for it, and while the credits may be a lot cheaper to obtain. So I would highly recommend working on that CME while you're in residency if you can. Oh, we got a shout out for Dr. Kevin. Says, I felt your review book was excellent. Thanks for that. It was very high yield.
Thank you.
So awesome. Let's see. I'm very excited to take the board, hopefully, but I'm disappointed with how a lot of the meds in our toolbox at this time are not covered by insurance. Yeah, you're preaching to the choir on that. So before running for the OMA board, I was the chair of the advocacy committee for the last 7 years. Now my mentor, actually the one who introduced me to obesity medicine, Becky Andrick, is the chair, and she's, kicking butt at that. So one of our big legislative priorities is improving coverage to these meds. There is more steam behind that than I've ever seen. It's definitely growing in that understanding that we have to get these meds covered. So, I would say on the advocacy side, like push for that. That may be pushing for it at your institution. If you're in an academic institution, like push for that to be covered on your state plan or your institution's plan. If you're in a hospital system, push for the meds to be covered through your hospital system. We're working in Colorado to put pressure on Medicaid to cover them. So maybe put pressure on your state's Medicaid program and figure out how you can do that. Our advocacy committee is working on all that. So if you need tools like the OMA advocacy committee, that's what we do in our free time, because we're dorks like that. So I agree that it is discouraging. At the same time, and on my website, there's a link about meds and prescribing, and teaches a lot about the meds at helpyourpatientsloseweight.com, and that's a free video. But phentermine works great. Is it Wegovy? No, but it is also like $12 a month. And I've had patients lose 20, 30% weight on phentermine with phentermine and nutrition change. So I'm a family doc, at least in my training program, we use cheap generic meds whenever possible. So we have a lot of meds that are powerful and are cheap. Phentermine, using generic naltrexone and bupropion, using generic phentermine and topiramate. So there are other tools in the toolbox, and it is only getting better. And I think we need to put pressure on institutions, we need to put pressure politically, and we need to put pressure on the drug companies to make these meds more readily available to patients. So, there's challenges in all our fields. There's lots of meds I'd like to be able to get for my patients outside of obesity medicine. And that's the framework with we work. How are you getting Ozempic covered in patients without diabetes? Magic. It's hard to do. It's getting harder by the day. Patients who really want to be on it are often getting it from Canada for about $300 a month. But I think that's, the insurance companies are not really playing game on that. Either it's covered or it's not. And, some people are getting it covered with like metabolic syndrome diagnoses. Some people apparently are getting it covered if the insurance plan covers Wegovy, but the Wegovy is not available right now. And so they're saying, like, look, this is the same drug. You cover it as Wegovy, like give them the Ozempic. Like, you're going to have to spend the money one way or another. That's kind of, what that looks like. And the meds are super frustrating. I've been telling my patients, I feel like I'm spending 20% of my time right now just trying to get people beds. And it is what it is. I don't know. Do you have any secrets?
Not really. I was going to say, I agree with kind of using some of those off-label medicines, especially for more Medicaid patients. But yeah, Ozempic is one of those that sometimes it's covered, sometimes it's not. I have used metabolic syndrome, NASH, things like that as well. And sometimes they'll cover them, sometimes they won't. It's frustrating. We're all in the same boat with you. And so we're trying to do our best and hoping that overall there's some of these GLP-1s like Victoza are going to be generic coming up next year. And so that's an exciting one that we're, it's may not be the strongest of the GLP-1s, but it's another tool in our toolbox that we can potentially use, especially for those patients. I'd also say if you have a patient that loses weight, if they meet criteria for diabetes, but then they lose weight, keep the diabetes diagnosis on there. You can put in remission, but sometimes, especially those GLP-1s, if you have a patient that has a diagnosis of diabetes, whether it's active or not, sometimes that can also help with kind of covering that gap, since some of those aren't specifically covered for obesity.
Yeah, but it is a bummer. I've had 2 patients who got diabetes in the last 2 months. They didn't have it and now they do. And I was like, the good news is I can get you some really good drugs now. Like, I was like, this is a sad state that I'm like happy my patients have diabetes. I've spent the previous 10 years of my career trying to prevent diabetes, but now I'm like, but now you can get Mounjaro. Now you can get, Ozempic. So it is the biggest challenge I think that we're facing. Lots more shout outs for how awesome Kevin's work is. Love your blog, especially the email quick reviews. Another shout out that his review book was helpful for the board exam. Talking about cheaper to take Viciamine now. Let's see. I'm absolutely willing to work with an ARNP. I don't know what the, if that's on helping you start your clinic or if you want a job, but either way, reach out to me. I'd love to chat. And let's see. Okay. So there were some earlier that were a little less focused on our topics. I'm going to get back to that. So, ER physician who launched her practice in January. Congrats. I'm so excited for you. That's awesome. Cash only. And can't bill for coaching, meaning I guess bill through insurance. So, I've traditionally been this, we should treat obesity with insurance person. And I still do believe that, but I also think if you're starting your own practice, that is really challenging. And I've done it for 7 years and it is very challenging. It's kind of like the drug thing where it's well, how much are you willing to deal with, to treat your patients? And I think the question is, not being able to bill for coaching, which I think you mean the intensive behavioral therapy, is what I'm thinking maybe you're talking about. And yes, right now, only primary care can bill for that. So both of these issues that have come up, covering meds and being able to bill for intensive behavioral therapy, are both covered by a bill that has been introduced to Congress called TROA. It's been introduced for 8 or 10 years. I can pop the link in here in a second. I'll look it up. But if you go to the Obesity Action Coalition, OAC, there's Google TROA and OAC, TROA, OAC. You can click a link, send it to your national representatives to say support this bill, because that is how we change coverage through Medicare for those things and everything else with Cascade. So, we have to do more than just be doctors sometimes and politically push some of these things too. But that being said, if you can make it work with cash, that's going to be your easiest way to get there. Let's see. Any other questions we didn't answer? It looks like maybe there's some in the Q&A section too. So I'll look at that. I also believe you mentioned that some CME receive credit towards the total so long as they have exercise and obesity focus. Yeah, the criteria for the CME is that it has the word obesity in it, and that it is AMA PRA category 1 approved. So that is what you're looking for if you're picking CME off of their list of category 1, or group 1, they call it. Okay, how do you react when you hear patients getting GLP-1 from random gyne when they have perfectly normal BMI, no medical problems, and no metabolic syndrome, just for cosmetic purposes? I'd say, are you single? I'd like to marry you if you have that kind of money. No, just kidding. So I think that treating obesity is more than just BMI. So there are people who qualify, in my experience, who may have a normal BMI. And I see this as often postmenopausal women. They have central adiposity. They may have a waist circumference of 37 inches. They have tiny little limbs, no muscle on them. Metabolically, their labs look terrible. And so they may have obesity based on body fat. I use an InBody here. I can see, oh, yep, you're 38% body fat. You technically have obesity based on your body fat. So sometimes people can't qualify for those meds. Weight loss, this field of weight loss, there's a lot of snake oil, right? So, and that's not snake oil, but there's people who want to lose weight just for vanity, or for non-health reasons. And I think putting too much energy into fighting that, like that's not my battle, right? I'm going to treat the patient in front of me. So I don't necessarily think that that's problematic in any way. And I've seen people who've come in and their BMI is like not that high. And I'm like, you don't really qualify for meds. Your BMI is not that high. Like, why don't you just keep eating healthy and exercise and like not stress about it? And then I see them for years and then all of a sudden they qualify for a med and like, well, like why, maybe I should be treating that pre-obesity, right? So I think that we can probably, discuss when these meds really should be used, but I think I'm much more concerned about them not being used enough than being overused personally. Just curious, have you been able to prescribe Mounjaro? Yes, I've had 2 patients with diabetes get their Mounjaro $25 per month coupon right now. So it's out there and people can get it. So that is awesome. All right. I think I answered all the questions I can see there. Let me double check the Q&A. Okay. I'm a psychiatrist with a cash only private practice. Do obesity medicine doctors do cash pay or only insurance? This question I love so much because when I started in this field, everyone was cash. Like when it was American Society of Bariatric Physicians, it was like everyone at the meeting took cash. And over the last 10 years, insurance-based is becoming much more normal, if not predominant, which is absolutely fabulous. That decreases stigma and bias and that improves access to care. But like, this is the original cash field. If you can make any practice work cash-based, it's obesity medicine. People, unfortunately, will pay an arm and a leg for weight loss. And they often do it at places that have much less value than us, right? They join these crazy nutrition programs. There's all sorts of things. So yes, absolutely, you can do cash-based. I think insurance is fantastic. I think that improves access to care and it treats this as a medical condition. But if any business, if any field of medicine can be cash-based, it's definitely obesity medicine. That being said, we need more and more people taking insurance for this. And that's also very rewarding. Are there listservs or Facebook groups? Yes, there is 2 great ones. So there's one called Evidence-Based Obesity Medicine. That is a very popular group that is very active. And then there is another one called Obesity Medicine for Physicians, I believe. I can try to put, how do I share, Kevin, are you more savvy? I don't know how to share Facebook groups.
Not on Zoom. I would know how to on Zoom.
I think you have to probably look for those on Facebook and then request to be added. And they usually ask, like, do you meet the criteria? So one is called Evidence-Based Obesity Medicine. That one's very active. And then there's another one that's pretty active called Obesity Medicine Interest Group for Physicians, I believe. So those are the 2 that are pretty active and have a lot of sharing in there.
There's also some groups, if you're interested in taking boards as well, that are specifically board related. So if you type in ABOM Exam, there's a couple of them. There's a 2022 prep group. 2021 is actually, there's one that's ABOM 2021 and beyond, and that one seems to have the most members, but there's a couple of those too. If you have any questions in there specific to related to the boards, they can help answer those and give some guidance. And it's kind of fun reading those because there's a lot of people that are kind of all in the same boat. They take their boards, they're getting ready to do what they want to do with obesity medicine, and they're trying to bounce ideas off of each other and things like that. So it's always fun.
Awesome. So thank you all for joining us. And I hope that was like inspiring and exciting. And feel free to reach out to us. And this is, again, just an awesome field to be a part of. And, if you're not already actively pursuing joining us in obesity medicine, it really is, I think, the best field for medicine. All right, take care. I'm going to go ahead and stop. All right. Oh, one new message. Thanks.